This is the audio lecture for Chapter 9, Maternal and Fetal Nutrition. Nutrition is one of the many factors that influence the outcome of pregnancy. However, maternal nutritional status is an especially significant factor, both because it is potentially alterable and because good nutrition before and during pregnancy is an important preventative measure for a variety of problems. These problems include birth of low birth weight, which is a birth weight of 2,500 grams or less, and preterm infants, those infants born between 20 and 37 weeks. Evidence is growing that a mother's nutrition and lifestyle affect the long-term health of her children. Thus, the importance of good nutrition must be emphasized to all women of childbearing potential. Key components of nutrition care during the preconception period and pregnancy include a nutrition assessment that includes appropriate weight for height and adequacy and quality of dietary intake and habits, diagnosis of nutrition-related problems or risk factors such as diabetes, PKU, and obesity, interventions based on an individual's dietary goals and plan to promote appropriate weight gain, ingestion of a variety of foods, appropriate use of dietary supplements, and physical activity, and last, evaluation as an integral part of the nursing care provided to women during the preconception period and pregnancy, with referral to a nutritionist or dietitian as necessary. This is figure 9-1, which is in your book, and it's talking about the factors that influence the outcome of pregnancy. Here you can see a person's health status, their socioeconomic status, their nutritional status, their personal status, such as culture, race, and ethnicity, their environment, their education, their family, and self-care. These are all influences that promote a successful outcome of pregnancy if they are in place. Nutrition needs before conception. The first trimester of pregnancy is a crucial one in terms of embryonic and fetal organ development. A healthful diet before conception is the best way to ensure that adequate nutrients are available for the developing fetus. Folate or folic acid intake is of particular concern in the periconception period. Folate is the form in which this vitamin is found naturally in foods, and folic acid is the form used in fortification of grain products and other foods and in vitamin supplements. Neural tube defects, which are failures in closure of the neural tube, are more common in infants of women with poor folic acid intake. Proper closure of the neural tube is required for normal formation of the spinal cord, and the neural tube begins to close within the first month of gestation, often before the woman realizes that she is pregnant. Maternal and fetal risk in pregnancy are increased when the mother is significantly underweight or overweight when pregnancy begins. Ideally, all women should achieve their desirable body weights before conception. This slide shows images of babies who were born with neural tube defects. Now we're going to talk about necessary nutrients during pregnancy. Nutrient needs are determined, at least in part, by the stage of gestation the pregnant woman is at. The amount of fetal growth varies during the different stages of pregnancy. During the first trimester, the synthesis of fetal tissue places relatively few demands on maternal nutrition. Therefore, during the first trimester, when the embryo or fetus is very small, the needs are only slightly increased over those before pregnancy. In contrast, the last trimester is a period of noticeable fetal growth when most of the fetal stores of energy sources and minerals are deposited. Thus, as fetal growth progresses during the second and third trimesters, the pregnant woman's need for some nutrients increases greatly. Factors that contribute to the increase in nutrient needs include the following. The first is the uterine placental fetal unit. Remember, the placenta is my baby's lifeline. Maternal blood volume and constituents. You need to know that during pregnancy, the total blood volume increases by about 40 to 50% over normal. Then we have maternal mammary development. The body is getting the mom prepared for lactation. And then metabolic needs, such as your energy or your kilocalories. These needs are met by carbohydrate, fat, and protein in the diet. Right now, there are no specific recommendations for the amount of carbohydrates and fat in the diet of the pregnant woman, but the intake of these nutrients should be adequate to support the recommended weight gain. The necessary minerals and vitamins. Table 9-1 in your textbook lists the recommendations for daily intakes of selected nutrients during pregnancy and lactation. This chart also lists the role they play in fetal development and the foods that contain these vitamins and minerals. Knowing what foods to instruct the patient to eat when certain vitamin and mineral deficiencies exist is an integral part of the OB nurse's responsibilities. So it would behoove you guys to make sure you take a look at Table 9-1 and know the different food types to eat for the different vitamin and mineral deficiencies. Also, your fat-soluble vitamins and water-soluble vitamins. Table 9-1 in your textbook talks about these, so make sure you look those over. Fluids and proteins. They're essential for the exchange of nutrients and waste products across the cell membrane. Having an adequate amount of fluid in the diet promotes good bowel function. Typically, I tell my pregnant women 10 to 12 glasses of fluid per day. I know your book says 6 to 8, but in Florida in the summertime, it's very hot, and especially if the women are outside, it's easily for them to become dehydrated. And what you'll learn as we continue is that dehydration sometimes will lead to preterm labor scares. So we want to make sure that our pregnant women stay hydrated. Water, milk, juices are other good fluid sources. And like I said before, dehydration may increase the risk of cramping, contractions, and preterm labor. Vitamin supplementation. Typically in pregnancy, there are 3 main supplements that we require the pregnant woman to include in their daily intake. This includes a prenatal vitamin, iron, and folic acid. We'll talk later about some of the things that you need to teach a woman who's on iron, like take with OJ to increase the absorption. It may cause GI upset, constipation. We want to tell her to take it on an empty stomach, things like that. And folic acid, typically, if a woman takes a prenatal vitamin, it has the amount of folic acid that the woman needs daily. We say 400 micrograms, which is equivalent to 0.4 milligrams a day. We know that folic acid decreases the risk of the infant developing neural tube defects. And then you have to know foods that are rich in folate, such as your green leafy vegetables, liver, peanuts, whole grain breads, and cereals. Now, a good thing to know that about a pregnant person in their diet, if the pregnant woman's diet is adequate, she's getting all the vitamins and minerals and nutrition she needs. The only vitamin supplementation she would need are prenatal vitamins, iron, and possibly folic acid. Now let's talk about weight gain. The desirable weight gain during pregnancy varies among women. The primary factor to consider in making a weight gain recommendation is the appropriateness of the pre-pregnancy weight for the woman's height. That is, whether the woman's weight was normal before pregnancy or whether she was underweight or overweight. Whenever possible, the woman should achieve a weight in the normal range for her height before pregnancy. Maternal and fetal risk in pregnancy are increased when the mother is significantly underweight or overweight before pregnancy, and when weight gain through pregnancy is either too low or too high. Again, the primary factor to consider is the appropriateness of the pre-pregnancy weight. Normal weight and underweight women with inadequate weight gain have an increased risk of giving birth to an infant with intrauterine growth restriction, or IUGR. A woman who comes in obese, whether it's pre-existing or new, it causes increased likelihood of birth complications such as emergency cesarean births, postpartum hemorrhage, wound or genital tract or urinary tract infections, birth trauma, and late fetal death. And most of these risks are linked to the mother having either gestational diabetes or sometimes even pre-gestational diabetes. All right, the BMI is a commonly used method of evaluating the appropriateness of weight for height. It's calculated by the following formula. Your BMI equals weight divided by the height squared. Recommended weight gain through pregnancy is determined largely by pre-pregnancy weight for height. The recommended total weight gain is as follows. Your underweight women, 12.5 to 18 kilos or 28 to 40 pounds. My normal weight women, 11.5 to 16 kilograms or 25 to 35 pounds. Overweight women, 7 to 11.5 kilos or 15 to 25 pounds. And obese women, 5 to 9 kilograms or 11 to 20 pounds. For twin gestations, the recommended total weight gain is 21 to 28 kilos or 46 to 62 pounds for women who are underweight before conception, 17 to 25 kilos or 37 to 54 pounds for normal weight women, 14 to 23 kilograms or 31 to 50 pounds for overweight women, and 11 to 19 kilograms or 25 to 42 pounds for obese women. But what I really want you guys to focus on is the recommended weight gain for a singleton pregnancy. The weight gain should be achieved through a balanced diet of regular foods chosen from all the different food groups. One thing to mention is that my adolescent pregnant teens, they should aim for the upper end of the recommended weight gain. So if my adolescent comes in as a normal BMI, and we know that women with normal BMI should gain 25 to 35 pounds, we would want the adolescent pregnant teen to gain around the 35-pound marker. We want them at the upper end. Patterns of weight gain. The optimal rate of weight gain depends on the stage of pregnancy. During the first and second trimesters, growth takes place primarily in maternal tissues. During the third trimester, growth occurs primarily in fetal tissues. During the first trimester of a singleton pregnancy, the average total weight gain is only 1 to 2 kilograms. Thereafter, the recommended weight gain increases to approximately 0.5 kilograms per week for an underweight woman and 0.4 kilograms per week for the woman of normal weight. The recommended weekly weight gain for overweight women during the second and third trimesters is 0.3 kilograms, and for obese women, 0.2 kilograms. This slide just shows the different weight gains. I know kilograms get you guys confused, so I put it into pounds, normal weight 25 to 35 pounds. And this is what you'll see mainly in practice. If they're underweight, we like them to reach their ideal body weight, then the 25 to 35 pounds. Overweight 15 to 25, obese less than 15. And then the patterns of weight gain in the first trimester, 3.5 to 5 pounds, and in the second and third trimesters, 12 to 15 pounds each trimester. This slide just shows the tissues contributing to the weight gain, and table 9-2 in your book has a graph that shows the different areas where the weight of pregnancy is put on. So a woman at 40 weeks gestation, increased stores of fat is approximately 4 to 6 pounds. The fetus 7 to 8.5 pounds. The placenta can be anywhere between 2 and 2.5 pounds, and the amniotic fluid is about 2 pounds. And like I said, table 9-2 has a chart that shows what contributes to the weight gain during pregnancy. Okay, pica and food cravings. Pica is the practice of consuming non-food substances such as clay, dirt, and laundry starch, or excessive amounts of foodstuffs low in nutritional value. Picas are often influenced by one's cultural background. So the races you see pica in the most include African American women, women from rural areas, and women with a family history of pica. The problem with pica is that it may cause more nutritious foods to be displaced from the diet because they're eating these non-nutritive substances. With your pica, the items consumed may interfere with the absorption of nutrients, especially minerals needed. Women with pica have been found to have lower hemoglobin levels than those women without pica. And typically, pica should be considered when a pregnant woman is anemic. Now, the hypothesis behind pica is that pica and food cravings, such as the urge to have ice cream, pickles, pizza, etc., during pregnancy are caused by an innate drive to consume nutrients missing from the diet. And these are just some pictures I found that kind of illustrate the different picas. We have someone who's eating soap. This one is cravings because it looks like peppers and maybe ice cream. This person is doing, that looks like gold medal is flour. You have someone eating dirt and ice picas. And I have a lot of people who aren't pregnant who have ice picas. More likely, usually what I see is my girls come in eating the Argo laundry starch. Usually they come into the hospital or to the clinic. They have a box of starch and a spoon, and they're just eating away at it. Another common pica that I used to see a lot was, like I said, the ice picas. And I would have pregnant women that would come in with mini coolers, and they would request ice, and they would know exactly which ice machine that they wanted their ice from, because we had 3 different ice machines on our floor, and they would tell me, I want the ice from the machine in the back, it has the best ice. And so I would fill it up for them, knowing that they had a pica. We would check their H&H's, and I was like, well, at least they're getting their fluid intake in. All right, adolescent pregnancy needs. Many adolescent females have diets that provide less than the recommended intake of key nutrients, including calcium and iron. Pregnant adolescents and their infants are at increased risk for complications during pregnancy and labor. Growth of the pelvis is delayed in comparison with growth in stature, and this helps explains why cephalopelvic disproportion and other mechanical problems associated with labor are common among young adolescents. And when I say the word cephalopelvic disproportion, we'll talk about this later in high risk labor and delivery. But CPD is basically the baby is too big to come out of the mom's body the natural way, so we end up doing cesarean sections. So, competition for nutrients between the growing adolescent and the fetus may also contribute to some of the poor outcomes apparent in teen pregnancies. Recommended weight goals are not different from those of an adult woman. Pregnant adolescents are encouraged to choose a weight gain goal at the upper end of the range for their BMI. Another important thing is that adolescent pregnancy increases the woman's risk of obesity later in life. And I want you guys to think about that, and I may ask you what your thoughts were in class. Other nutritional issues during pregnancy, preeclampsia. The cause is still unknown. There has been speculation that the poor intake of various nutrients might contribute to development of preeclampsia, but no definitive evidence exists. At present, a diet adequate in the recommended nutrients, see Table 9-1 in your textbook, along with the use of supplements that provide micronutrients both before and during pregnancy, appears to be the best means of reducing the risk of preeclampsia. Exercise during pregnancy. Moderate exercise during pregnancy yields numerous benefits, including improving muscle tone, potentially shortening the course of labor, and promoting a sense of well-being. If no medical or obstetric problems contraindicate physical activity, pregnant women should engage in a minimum of 30 minutes of moderate physical exercise on most, if not all, days of the week. Two nutritional concepts are especially important for women who choose to exercise during pregnancy. First, a liberal amount of fluid should be consumed before, during, and after exercise because dehydration can trigger premature labor. Second, the calorie intake should be sufficient to meet the increased needs of pregnancy and the demands of exercise. Nutrient needs during lactation. Nutritional needs during lactation are similar in many ways to those during pregnancy. Needs for energy or calories, protein, calcium, iodine, zinc, the B vitamins, and vitamin C remain greater than non-pregnant needs. The recommendation for some of these are slightly to moderately higher than during pregnancy, and the table in your book 9-1 also lists the requirements of nutrients needed for the woman who is breastfeeding. This allowance covers the amount of the nutrients released in the milk as well as the need of the mother for tissue maintenance. The recommended energy intake for the first 6 months is an increase of 330 kilocalories more than the woman's non-pregnant intake. It becomes difficult to obtain adequate nutrients for maintenance of lactation if total caloric intake is less than 1,800 calories. Because of the deposition of energy stores, the woman who has gained the optimal amount of weight during pregnancy is heavier after birth than at the beginning of pregnancy. As a result of the caloric demands of lactation, the lactating mother usually experiences a gradual but steady weight loss. Smoking, alcohol intake, and excessive caffeine intake should be avoided during lactation. Smoking not only may impair milk production but also exposes the infant to the risk of passive smoking. It is speculated that the infant's psychomotor development may be affected by maternal alcohol use, and alcohol use may impair the milk ejection reflex. Caffeine intake can lead to a reduced iron concentration in milk and consequently contribute to the development of anemia in the infant. Okay, care management. During pregnancy, nutrition plays a key role in achieving an optimal outcome for the mother and her unborn baby. The health history. Chronic maternal may affect a woman's nutritional status and dietary needs. In women with illnesses that have resulted in nutrition deficits or that require dietary treatment, it is extremely important for nutritional care to be started and for the condition to be optimally controlled before conception. A registered dietitian can provide in-depth counseling for the woman who requires medical nutrition therapy during pregnancy and lactation. Knowing the mother's usual maternal diet, the woman's usual food and beverage intake, the adequacy of her income and other resources to meet her nutrition needs, and dietary modifications such as food allergies and intolerance, and all the medications and nutrition supplements being taken, as well as Pica and cultural dietary requirements should be ascertained. In addition, the presence of severity of nutrition-related discomforts of pregnancy, such as morning sickness, constipation, and heartburn, should be determined. The nurse should be alert to any evidence of eating disorders such as anorexia and bulimia, or frequent and rigorous dieting before or during pregnancy. The physical exam. A careful physical exam can reveal objective signs of malnutrition. It is important to note, however, that some of these signs are nonspecific and that the physiologic changes of pregnancy may complicate the interpretations of physical findings. Anthropometric measurements. At a minimum, the woman's height and weight must be determined at the time of her first prenatal visit, and her weight should be measured at each subsequent visit. Laboratory testing. The only nutrition-related laboratory testing needed by most pregnant women is a hematocrit or hemoglobin measurement to screen for the presence of anemia. Because of the physiologic anemia of pregnancy that usually happens during the second trimester, the reference values for hemoglobin and hematocrit must be adjusted during pregnancy. Adequate dietary intake. During pregnancy, the pregnant woman must understand what adequate weight gain during pregnancy means. She needs to recognize the reasons for its importance and be able to evaluate her own gain in terms of the desirable pattern. Your postpartum mothers. An important goal of postpartum nutrition is for the woman to lose the weight gained during pregnancy. Retention of this weight can contribute to overweight or obesity and the development of later health problems, including the metabolic syndrome, cardiovascular disease, and diabetes mellitus. Daily food guide and menu planning. The daily food plan, which you can see on table 9-3 in your textbook, can be used as a guide for educating women about nutritional needs during pregnancy and lactation. This food plan is general enough to be used by women from a wide variety of cultures, including those who follow a vegetarian diet. Medical and nutrition therapy. During pregnancy and lactation, the food plan for women with special medical nutrition therapy may have to be modified. The registered dietitian can instruct these women about their diets and assist them in meal planning. However, the nurse should understand the basic principles of the diet and be able to reinforce the teaching. Counseling about iron supplementation. See the patient teaching box on page 245 in your textbook that talks about iron supplementation. I know you guys had pharmacology already, and many of you know the different effects that iron has on a person. Also, my plate, or the at the web address listed here, choosemyplate.gov. It can be used as a guide to making daily food choices during pregnancy and lactation, just as it is during other stages of the life cycle. coping with nutrition-related discomforts of pregnancy. In your book, Review Box 9-8, Suggestions for Managing Nausea and Vomiting During Pregnancy. Constipation, improved bowel function generally results from increasing the intake of fiber in the diet of the pregnant woman. Pyrosis or heartburn is usually caused by reflux of gastric contents into the esophagus. This condition can be minimized by eating small, frequent meals rather than 2 or 3 larger meals daily. Also, because fluids increase the distension of the stomach, they should not be consumed with foods. The woman needs to drink adequate amounts of fluids between meals. Also, teaching the woman to avoid spicy foods may help alleviate the problem. Reflux can be exacerbated or worsened by lying down immediately after eating and wearing clothing that is tight across the abdomen. Cultural influences. Consideration of a woman's cultural food preferences enhances communication and provides a greater opportunity for following the agreed-on pattern of intake. Women in most cultures are encouraged to eat a diet typical for them. The nurse needs to be aware of what constitutes a typical diet for each cultural or ethnic group present in his or her patient population. However, several variations may occur within one cultural group. Thus, a careful exploration of individual preferences is needed. The vegetarian diet. The vegetarian diet represents another cultural effect on nutritional status. Foods basic to almost all vegetarian diets are vegetables, fruits, legumes, nuts, seeds, and grains, but with many variations. Lacto-vegetarians include milk products. Lacto-ovo-vegetarians consume eggs and dairy products in addition to plant products. Strict vegetarians or vegans consume only plant products. All of these types of vegetarian diets, if they are well planned, can be nutritionally adequate for pregnant and lactating women. Because vitamin B12 is found only in foods of animal origin, the vegan diet typically is deficient in vitamin B. Okay, let's do a case study. You are the nurse working with prenatal patients at the health department. You meet Miss Brooks, a 29-year-old, gravida 1, para 1, at 28 weeks of gestation. Ms. Brooks began prenatal care at 12 weeks. Her fetal screening ultrasound at 18 weeks revealed normal anatomy, and all of her prenatal laboratory results have been normal or negative. The pregnancy was not planned, but she and her partner are delighted and plan to be married in 2 weeks. Now, I will give 10 fake bonus points for anyone who can pick out the discrepancy in this slide. Ms. Brooks had a pre-pregnancy BMI of 32 and has a history of borderline chronic hypertension. She has been counseled by the physician to gain no more than 15 pounds during her pregnancy. As you check her in for her visit, you note that her total weight gain during pregnancy is 12 pounds. Her blood pressure is 138/86. Her urine is negative for protein and glucose. When Ms. Brooks looks at the scale, she says, "What am I going to do? I have 3 months to go." She begins to cry. Okay, let's start answering these questions. The first one, what should you do and say? You want to get a 24-hour recall of her diet and begin with basic suggestions. You want to help calm the patient. You may take her to an exam room for privacy. Sit down and offer her your attention. Acknowledge her disappointment and recognize that it may be hard to limit weight gain. Once she is calm, let her know that you can offer her some help with meal planning. You're going to want to identify foods that Ms. Brooks likes and help with alternatives that may be lower in fat, carbohydrates, and sodium. Ask about level of activity and discuss appropriate non-strenuous ways to increase activity. Ask about her partner's eating habits and his level of support of her diet. Offer to include her partner in your teaching and recommendations. Help her set a reasonable weight goal for her next visit in 2 weeks. Consider scheduling an additional nurse visit sooner than 2 weeks to check on diet and weight goals. Gently remind her of her risk for increasing blood pressure during the third trimester and the importance of adhering to her goal for herself and her baby. Congratulate her on all of the positive things she is doing to grow a healthy baby. Encourage her to bring a 3-day diet history to her next visit so that you can review it fully with her. Offer to help explore support groups for weight issues in her community. The second question, what risk factors are associated with obesity in pregnancy? Some of the risk factors are gestational diabetes, preeclampsia, neural tube defects, microsomia, cesarean birth, and postpartum complications. The third question, why was the urine checked for protein and glucose at the visit? Proteinuria may indicate early signs of pregnancy-induced hypertension or preeclampsia, and glucose could indicate signs of diabetes. Now, here's a question. Assessment of a woman's nutritional status includes a diet history, medication regimen, physical examination, and relevant laboratory tests. A maternity nurse performing such an assessment should be aware that A. Oral contraceptive use may interfere with the absorption of iron. B. Illnesses that have created nutritional deficits such as PKU may require nutritional care before conception. C. The woman's socioeconomic status and educational level are not relevant to her examination. They are the province of the social worker, if anybody. Or D. The only nutrition-related laboratory test most pregnant women need is testing for diabetes. If you answered A, you are incorrect. Oral contraceptive use may interfere with the absorption of folic acid. Iron deficiency can appear if placement of an intrauterine device resulted in blood loss. Answer B is correct. A registered dietitian can help with therapeutic diets. Answer C is incorrect. A woman's finances affect her access to good nutrition. Her education or lack thereof can influence the nurse's teaching decisions. Answer D is incorrect. The nutrition-related laboratory test that pregnant women usually need is a screen for anemia or a hemoglobin hematocrit. This concludes the lecture for Chapter 9, Maternal and Fetal Nutrition. Thank you.